Okay, so welcome to the deep dive. We take really complex stuff, source material, and basically pull out the key knowledge you need to get up to speed fast.
Yeah.
And look, in today's world, we're just so reliant on our vision, right? But how many of us actually understand how it works? Or, maybe more importantly, how it can fail?
Mm-hmm.
And when vision impairment happens, it's not just, an inconvenience.
Yeah.
It can seriously reduce your quality of life, your independence, especially in a society pretty much built for people who can see well.
That's exactly the paradox, isn't it? And we think this basic knowledge, it shouldn't just be for eye doctors. I mean, think about conditions like cataracts, macular degeneration, glaucoma, where they're becoming so common as we age. Understanding the basics is just, well, it's crucial for managing your own health long term.
Right. So our mission today, what we're trying to do is take a whole stack of foundational ophthalmology research, really solid stuff, and pull out the critical diagnostic insights. We're going beyond just, getting your prescription checked.
Yeah, way beyond.
We really want to focus on how the eye acts like this window into your whole body's health, how your eye doctor might actually be the first one to spot signs of serious, non-eye related diseases, maybe even life-threatening ones.
Think of it like this, your routine eye exam. It's not just about seeing the world more clearly, it's about getting a clear view of what's going on inside you. So yeah, we'll be diving into those surprising connections between the eye and the rest of the body, the essential diagnostic tools, and some really critical, time-sensitive threats everyone should probably know about.
Okay, let's jump right in. The sources talk about the eye as an internal mirror, and it really is amazing how these delicate structures, way in the back of the eye, the retina, especially how they can just reflect chronic damage from systemic illnesses. High blood pressure is maybe the biggest example.
Oh, absolutely. High blood pressure, or arterial hypertension as it's technically called, it's famous for having no symptoms for years, right? But it leaves clear signs in the eye. We call these hypertensive fundus changes.
Fundus changes. So changes at the back of the eye.
Exactly. The fundus is the back internal surface. And unlike most blood vessels hidden away in your body, we can look directly at the retinal arterioles. We can actually see the stress they're under. They might look constricted, their walls thickened. You see these characteristic changes where they cross over each other.
And spotting these changes.
Yeah.
It's obviously important for the eye, but what does it tell you about the rest of the body? What's the big risk?
It signals a much higher risk for major cardiovascular events systemically. I mean, the vessels in your retina, structurally, they're pretty much identical to the small vessels in your brain and your heart.
Ah, okay, so damage there means damage elsewhere.
Precisely. If we see damage in the eye, it's a very strong indicator there's damage happening elsewhere, too. We're talking significantly increased risks for things like stroke apoplex and heart attacks, myocardial infarction. The eye essentially gives you this visible, localized report card on the overall health of your entire vascular system.
And the sources get really specific here. They mention these things called cotton wool spots. What are those exactly? And why are they such a strong predictor, especially for stroke?
Right, cotton wool spots. They sound soft, but they're actually quite serious. They're essentially tiny, localized infarcts of the nerve fiber layer. Little areas where the retinal tissue has, died off due to lack of oxygen from blocked microvessels.
Like mini strokes in the eye itself.
Kind of, yeah. And the predictive power is startling. The research points to this. If these spots are visible in the retina, the risk of having a future stroke jumps to about 6%. If they're not there, the risk is down around 1%.
Wow, that's a six-fold difference. Signaled by something maybe the size of a pinhead? So the eye is showing a history of these tiny vascular events the person maybe never even felt.
Exactly. It confirms their small vessel disease isn't just present, it's active, it's aggressive, it's a huge red flag. It tells the primary care doc or the cardiologist, hey, you need to get this blood pressure under really tight control because the body's clearly struggling to protect its most delicate vascular networks.
Okay, let's shift to another massive systemic issue, diabetes mellitus. The source material straight up calls this the most frequent cause of blindness and severe visual impairment in industrialized countries. That's a heavy statement. Uncontrolled blood sugar is the biggest threat to vision.
It is the leading cause, unfortunately. Diabetes damages tiny blood vessels, the microvasculature, everywhere. But that damage is functionally catastrophic in the retina. This leads to diabetic retinopathy. And clinically, we tend to break it down into two main stages.
Okay, so let's start with the first one, the non-proliferative stage. What are the early signs you'd see?
Non-proliferative basically means things are leaking and getting blocked, but new vessels aren't growing yet. So you see these characteristic tiny dots or spots of blood punctate or spot hemorrhages. You see microaneurysms, which are like little balloon-like outpouchings in the vessel walls. And hard exudates, those are yellowish deposits of fats and proteins that have leaked out.
So leakage and blockage, but the basic structure is still there.
Right, the fundamental architecture is intact at this stage. The problem is localized leakage and some loss of blood flow. But then things can escalate.
And that's the proliferative stage. When does it cross that line?
It crosses when the retina gets so starved of oxygen because all those small vessels are getting blocked off that it starts sending out distress signals. It basically screams, "Grow new blood vessels!" This is called neovascularization.
Trying to compensate, but it goes wrong.
Exactly. It's a desperate measure, and these new vessels are abnormal, pathological, they're incredibly fragile, they grow in the wrong places, often sprawling across the retinal surface or even into the vitreous gel, the jelly inside the eye. And because they're so fragile, they bleed very easily.
And bleeding would cause sudden vision loss, I imagine.
Oh yeah, a bleed into the vitreous can cause sudden dramatic floaters or just a complete blackout of vision. But the even bigger long-term problem is the scar tissue, the fibrous tissue that grows along with these bad vessels. We call these traction membranes.
Traction, like pulling.
Exactly like pulling. As the scar tissue matures and contracts, it literally pulls the retina away from the back wall of the eye. That's a tractional retinal detachment, and sadly, that often leads to permanent, irreversible blindness.
That sounds devastating.
It is. And we absolutely have to mention diabetic macular edema, too. All that leakage from the damaged vessels. It can pool right in the center of the retina, the macula, causing it to swell up. That edema leads to blurred vision, distorted vision, making reading or recognizing faces really difficult.
Wow. Okay, the complexity here, it really brings us to something that seems like it should be obvious but often gets missed. Medication side effects.
Yeah.
Patients forgetting to mention things during their history, the anamnesis.
That is such a common challenge when taking a patient's history. Someone might have had high blood pressure their whole life, but it's perfectly controlled now with medication. So they might think, oh, I don't need to mention that. I feel fine.
Right, because they don't feel sick.
Exactly. But the fact they're on that specific medication, say a beta blocker, tells the ophthalmologist a huge amount. It confirms the underlying condition. And clinically, the drug itself might be causing or contributing to what we're seeing in the eye. So yes, insisting on getting a full current medication list is absolutely essential. You just have to ask.
And then there's the flip side, which is kind of shocking eye drops causing systemic problems. We think of eye drops as just staying in the eye, right? But you mentioned beta blocker eye drops.
Yeah, this is a classic example. Many eye drops, especially the powerful ones used for glaucoma, contain drugs like beta blockers. When you put the drop in your eye, some of it inevitably grains through your tear duct system, the nasolacrimal duct, and ends up in your nasal cavity.
And the lining of the nose is full of blood vessels.
Highly vascular, exactly. So the drug gets absorbed directly into the bloodstream, and crucially, it bypasses the liver's first-pass metabolism. The liver normally breaks down a lot of drugs taken orally.
So it's like getting a direct systemic dose.
It can be potent enough to actually slow the heart rate-caused bradycardia, or even worsen breathing problems like COPD, chronic obstructive pulmonary disease. It's a real risk, particularly for elderly patients who might already have heart or lung issues.
Is there really a simple way to prevent that systemic absorption? Just blocking the drain?
It sounds basic, but yes, it's effective. It's called punctal occlusion. Right after putting the drop in, you just gently press on the little opening, the punctum at the inner corner of your lower eyelid near your nose. Holding that for a minute or two blocks the drainage path.
Giving the eye time to absorb what it needs locally.
Exactly. It keeps more of the drug on the eye surface where it's needed and stops so much from draining down into the nose and getting into the bloodstream. Simple, but important.
Okay, beyond eye drops, let's quickly hit some of those systemic drugs mentioned in the sources that have specific eye toxicities. Chloroquine.
Right, chloroquine. Used for things like rheumatoid arthritis, lupus, sometimes malaria prevention. Long-term use carries a known risk of a very serious maculopathy, damage to the macula, the central vision area. And the scary part is it can be progressive and often irreversible even after stopping the drug. So regular eye exams, specific testing are absolutely mandatory for anyone on long-term chloroquine.
And tamoxifen. That's widely used in breast cancer treatment.
Tamoxifen can cause changes in the retinal pigment epithelium, the layer beneath the retina. Sometimes this leads to crystalline deposits in the retina, giving the back of the eye a kind of pepper and salt look on examination. Often it doesn't cause symptoms early on, but it definitely needs monitoring to make sure that crucial pigment layer isn't being significantly compromised.
Even things like drugs for erectile dysfunction, sildenafil, for example.
Yep, the phosphodiesterase 5 inhibitors, like sildenafil, they work by targeting the PDE5 enzyme, but there's a similar enzyme in the retina, PDE6, which is really important for how photoreceptors work, how you see.
So there's some cross-reaction.
There can be. That's thought to be why some people get temporary visual side effects, like seeing things with a blue tinge or having trouble distinguishing colors. More seriously, though rarely, these drugs have been linked to episodes of ischemic optic neuropathy, basically, a stroke of the optic nerve head, possibly due to effects on blood flow. It's rare, but potentially permanent.
Okay, let's wrap up this systemic tour with thyroid eye disease, historically called morbus Basedow or Graves' disease. We know the classic triad of symptoms, but what's actually happening in the eye socket?
Right, the classic Merceburger trias. You get the goiter, struma, the fast heart rate, tachycardia, and the eye signs, the most obvious being exophthalmos, where the eyeballs protrude or bulge. The key thing happening is autoimmune inflammation within the orbit, the eye socket.
So it's not the eyeball itself growing, it's the stuff around it.
Exactly. The immune system mistakenly attacks tissues in the orbit. This causes an increase in the orbital fat tissue, and the muscles that move the eye, the extraocular muscles, get really thickened and inflamed. All this extra volume inside the bony orbit, which can't expand, physically pushes the eyeball forward. That's the exophthalmos. And those thickened muscles don't move well, restricting eye movements.
And that buildup of pressure inside the orbit, that sounds like the real danger to vision. Can it squeeze the optic nerve?
That's the most severe complication. If the pressure inside the orbit gets too high, it starts to compress the optic nerve right where it enters the back of the eye. This can cause progressive vision loss, damage to the visual field. It's a true emergency. In really bad cases, the only way to save sight is surgery orbital decompression, where they actually remove parts of the bony walls of the orbit to make more space and relieve that pressure on the nerve.
Wow. Okay, that really highlights the need for intervention, which brings us nicely to the tools and procedures used in the clinic every day. And it all has to start with the basics, right? The comprehensive anamnesis, taking the patient's history.
Absolutely. If the first part showed us why the eye reflects systemic health, this part is about how we find out. And that history, it's got to be thorough. It's not just asking, can you see? Okay.
Right.
You need the current complaints, sure, but also every past eye problem, any surgeries, medications they're taking, family history, especially things like glaucoma, and really importantly, their social and occupational history.
Yeah, the occupational part feels particularly relevant now. The sources highlighted screen work Bildschirmarbeit as the most frequent modern eye strain. Is it really the screen itself, the light, or radiation?
Mostly no. People worry about blue light, and maybe there's something there long term, but the immediate strain, the day-to-day symptoms, that's usually down to simple mechanics. Reduced blink frequency.
Just not blinking enough.
Exactly. Normally you might blink, say, 15 to 20 times a minute without thinking about it. But when you're really focused on a screen reading, coding, gaming, whatever that rate can plummet, sometimes down to only 5 or 7 blinks per minute.
And why is blinking so important?
Blinking is what spreads your tear film evenly across the cornea, the front surface of your eye. It keeps it lubricated, smooth, and protected. If you don't blink enough, the tear film evaporates too quickly, it becomes unstable, and you get dry spots.
Leading to that gritty, burning feel.
Precisely, that classic dry eye complex. Itching, burning, feeling like there's sand in your eyes, maybe some blurry vision that clears when you blink, and just getting tired eyes really quickly. Often the fix involves things like reminding yourself to blink, using specific lubricating eye drops, or maybe even special computer glasses.
And staying on history for a sec, allergies, specifically to eye drop preservatives. Why is asking about allergies, maybe even seeing an allergy pass, so critical in ophthalmology?
Because many eye drops, even over-the-counter ones, contain preservatives to keep them sterile. But for some people, these preservatives can cause chronic irritation, allergic reactions, or even something called toxic conjunctivitis if used long-term.
So the treatment could be making the problem worse.
Potentially, yes. If someone has an underlying eye surface issue, like chronic dry eye or inflammation, and you put them on a preserved drop, you might just be adding fuel to the fire. That's why, especially for any long-term treatment, knowing about preservative allergies is vital. Often we need to switch patients to preservative-free options, which come in single-use vials usually.
Got it. Okay, let's move to a core diagnostic, tonometry. Measuring the eye's internal pressure. This is still ground zero for glaucoma detection, right?
It is, because elevated intraocular pressure, or IOP, is still the single most significant and usually the only modifiable risk factor for developing glaucoma. Glaucoma is that progressive disease that damages the optic nerve and causes irreversible loss of your peripheral vision. If you don't measure the pressure, you can't properly assess the risk.
And the gold standard for measuring it is still the Goldman tonometer.
Goldman applanation tonometry, yes. It's considered the international gold standard for accuracy.
Can you break down how it works? That Ember-Fick law sounds complicated.
It's actually based on a pretty elegant physics principle. The Ember-Fick law basically says that for an ideal sphere, thin, perfectly flexible, dry, the pressure inside is directly related to the force needed to flatten a specific area of its surface.
Okay.
So with the Goldman tonometer, the eye doctor first puts numbing drops and a yellow dye, fluorescein, in your eye. Then they use this little prism mounted on the slit-lamp microscope. They gently touch the prism to your cornea and apply just enough force to flatten a very specific circle, exactly 3.06 millimeters in diameter.
Why that specific number?
Because at that diameter, the cornea's natural resistance to bending is perfectly counteracted by the surface tension of the tear film pulling the prism towards the eye. It cancels things out, so the force needed is directly proportional to the IOP. The dial on the tonometer gives a reading right in millimeters of mercury of mmHg.
And the normal range is usually quoted as, what, 12 to 22 millimilli-Hg. But you mentioned a big catch, corneal thickness. How does that mess up the reading?
This is probably the most critical thing to understand about IOP readings. The Ember-Fick law assumes that ideal, thin, flexible sphere. But real corneas aren't like that. They have varying thicknesses. If a patient has a naturally thick cornea, it's just stiffer. It resists being flattened more.
So it takes more force on the tonometer.
Exactly. Which means the tonometer overestimates the true IOP. You get a falsely high reading.
And the opposite for thin corneas.
Right. A thin cornea is more flexible, easier to flatten, so it takes less force, and the tonometer underestimates the true IOP, giving you a falsely low reading.
So someone could have dangerously high pressure, say 24 millimilli-Hg, but if they have thin corneas, the Goldman might read only 18. And everyone thinks it's fine.
That's the danger, precisely. That patient could be developing glaucoma damage while their pressure is thought to be under control. This is why measuring corneal thickness, a procedure called pachymetry, is now a standard part of a glaucoma workup. We measure the thickness and then use correction formulas, or just factor it into our overall risk assessment for that patient. You can't just take the raw Goldman number at face value anymore.
Okay, that's crucial. Now, moving from pressure to actual function, let's talk about mapping the visual field with perimetry. How is this different from just reading an eye chart?
Yeah, they test two totally different things. Visual acuity, the eye chart, tests your central vision, how sharp things are right where you're looking at the fovea. Perimetry, or visual field testing, assesses your peripheral vision. It maps out the entire area you can see while you're staring straight ahead at a fixed point.
And it's about detecting light, not just reading letters.
Exactly. The most common type is threshold perimetry. You sit looking into a bowl-shaped machine, fixating on a central target. Then, tiny spots of light of varying brightness are flashed at different locations in your peripheral view. You click a button whenever you see one.
So it finds the dimmest light you can possibly see at each spot.
That's the threshold, yes. It measures the minimum light intensity you need to detect the stimulus at hundreds of points across your visual field. The machine builds a map based on your responses. Areas where you need much brighter light, or where you miss the light altogether, show up as defects on the map. We call those areas scotoma.
Scotoma, blind spots.
Sort of. A scotoma is any area within the visual field where your light perception is reduced or absent compared to the surrounding area. We all have one physiological scotoma, the natural blind spot where the optic nerve enters the eye, because there are no photoreceptor cells there. But finding other scotomas is usually pathological. A central scotoma, affecting your direct line of sight, is really bad news, often indicates macula problems or optic nerve issues affecting central fibers. Other patterns of peripheral loss can be characteristic of glaucoma, stroke, brain tumors. The pattern of the visual field loss gives us huge clues about where the problem might be, sometimes even before the patient notices anything wrong themselves.
Okay, so we've covered the health checks and the diagnostics. Let's pivot now to something maybe more familiar. Fixing focus, dealing with common refractive errors. And we have to start with the one that gets almost everyone eventually. presbyopia.
Ah, yes, presbyopia, the inevitable old eye. It's simply the natural physiological loss of accommodation. That's the eye's ability to change its focus, to shift from looking far away to looking up close.
And it's not weak muscles, right? It's the lens itself.
Exactly. It's not that the focusing muscle, the ciliary muscle, gets weak. It's that the lens inside your eye, over time, naturally hardens and loses its elasticity. It just can't physically change shape as easily anymore when the muscle tries to contract.
The sources pointed out a really steep decline in focusing power with age.
It's dramatic. Accommodation is measured in diopters, DPT. A typical 20-year-old might have, say, 10 diopters of focusing range. By the time you're 50, that might be down to only 2 diopters. And by age 70, it's pretty much 0, which means reading glasses Lesbril become essential for any kind of near work. Your eye just can't add that extra focusing power needed anymore.
Does everyone hit this wall at the same age? Like 40 or 45?
Not quite. People who are naturally farsighted hyperopes tend to notice it much earlier, maybe even in their late 30s.
Why sooner for them?
Because hyperopes are already using some of their accommodation just to see clearly in the distance. Their eye's natural focus point is behind the retina, so they're dipping into their focusing reserve constantly. As that total reserve starts to shrink with age due to presbyopia, they feel the loss of near vision much sooner because they just had less extra accommodation to begin with. Nearsighted people, myopes, often notice it later.
Okay, that makes sense. Now, what about when the two eyes aren't matched? Anisometropia. When there's a big difference in prescription between the eyes, why can wearing glasses sometimes cause problems?
Right, anisometropia just means unequal refractive power. Maybe one eye is nettish 5.000 diopters nearsighted, and the other is only 1.000. If you correct that big difference with glasses, you run into a problem called anisoconia.
Anisoconia.
Different image size.
Exactly. The strong minus lens for the nettish 5000 eye makes the image seen by that eye appear significantly smaller than the image seen by the other eye through its weaker minus 1.00 lens.
And the brain doesn't like that.
The brain really struggles to fuse two images of noticeably different sizes into one single, comfortable 3D picture. It can lead to eye strain, headaches, a feeling of visual discomfort, or even outright double vision, diplopia. It's a major limitation for correcting large amounts of anisometropia with spectacles.
But here's the interesting bit. Contact lenses seem to solve this problem. Why? What's different about contacts? It all comes down to where the lens sits relative to the eye. This is about vertex distance. Glasses sit maybe 12-14 millimeters away from the cornea. At that distance, the magnifying or minifying effect of the lens power is quite significant.
Okay.
Contact lenses, however, sit directly on the cornea. The vertex distance is essentially 0. And because they're right on the eye, they cause very little change in the size of the image that actually lands on the retina. So even with a big difference in prescription between the two eyes, the image sizes remain much more similar, and the brain can fuse them easily. It's a huge advantage of contacts for people with significant anisometropia.
That's clever. Okay, so that leads us into surgical corrections, which have come such a long way. Let's start with the most well-known one, LSIK. Laser in situ keratomolysis. How does making that flap help reshape the eye?
A LASIK is all about precisely reshaping the front surface of the eye, the cornea, to change its focusing power. The first step is creating a very thin, hinged flap in the outer layers of the cornea. This is usually done either with a highly precise mechanical blade called a microkeratome, or, more commonly now, with a femtosecond laser which uses tiny laser pulses to create the flap.
And then you lift the flap.
Yep. The surgeon carefully lifts that flap, like opening a book cover, exposing the corneal tissue underneath, which is called the stroma. This is the main structural part of the cornea.
And that's where the reshaping happens.
Exactly. Then an excimer laser is used. This laser uses cool ultraviolet light to vaporize or ablate microscopic amounts of stromal tissue without burning it. It removes tissue in a very precise pattern based on the patient's prescription, removing more centrally for myopia, more peripherally for hyperopia, or in specific patterns for astigmatism.
And then just put the flap back.
Put the flap back down, smooth it out, and it basically sticks back in place almost immediately, kind of like a natural bandage. Healing is usually quick, discomfort is minimal. LASIK works really well for moderate amounts of nearsightedness, myopia, typically up to about manic of 8 diopters, and also for farsightedness, hyperopia, and astigmatism within certain ranges.
But what about people with really high prescriptions outside the LASIK range, or people who are already dealing with presbyopia and want to fix that too? Lens-based options come in then.
Right. For higher powers, or if presbyopia is the main issue, we often look at procedures involving artificial lenses inside the eye. There are two main approaches.
Okay, what's the first?
The first is implanting phakic IOLs. Phakic means the patient's natural lens is still there, it hasn't been removed. These are like implantable contact lenses.
Right.
Tiny artificial lenses are inserted into the eye, usually either just in front of the iris or slipped in just behind the iris, but in front of the natural lens.
So an add-on lens inside the eye?
Essentially, yes. An advantage is you keep your natural lens and its remaining accommodation if you're not fully presbyopic yet. It might also carry slightly less risk of certain retinal complications compared to lens removal. The potential downside is a slightly higher risk of developing a cataract in your natural lens later on, possibly due to proximity or altered fluid dynamics.
And the second, more drastic option, taking out a clear lens.
That's refractive lens exchange, RLE, sometimes called clear lens extraction, CLE. This is basically performing cataract surgery, but on an eye where the natural lens isn't cloudy yet, it's still clear.
Why do that?
It's typically done for patients who are already significantly presbyopic, usually over 50, and often have high refractive errors that aren't ideal for LASIK. You remove the natural lens entirely and replace it with an artificial intraocular lens, IOL, that has the desired corrective power built in.
But you lose something significant there, right?
You lose all remaining natural accommodation instantly and permanently, because the artificial IOL can't change shape like the natural lens could. However, since these patients are usually already quite presbyopic, they weren't using much accommodation anyway. And the big advantage of RLE is that we can now implant advanced technology IOLs, multifocal or extended depth of focus lenses that can give good vision at distance, intermediate, and near, reducing or eliminating the need for glasses altogether. Plus, you'll never get a cataract later because the natural lens is gone.
Okay, we absolutely need to shift gears now and talk about the real emergencies. Situations where time is incredibly critical, minutes or hours can mean saving sight versus permanent blindness. Let's start with the glaucoma attack, acute angle closure glaucoma.
Yes, this is a true classic ophthalmic emergency. The German term Winkelblock glaucoma, angle block glaucoma, really captures it. What happens is a sudden, complete blockage of the drainage angle inside the eye where the fluid normally flows out.
So the fluid builds up instantly.
Instantly. The pressure inside the eye skyrockets. Normal IOP is, say, below 22 mmHg. In an acute attack, it can shoot up to 55, 60, even 70 mmHg or higher. It's incredibly painful. If you were to gently touch the eye through the closed eyelid, it would feel literally rock hard compared to the other eye.
And the symptoms, they aren't always obviously eye-related, which sounds dangerous for getting the right help quickly.
That's a huge problem. Yes, the eye itself is usually very red. The cornea looks hazy or steamy because it swells up, corneal edema, and the pupil often gets stuck in a mid-dilated position and doesn't react to light properly. But the pain is intense, often described as a deep ache in or around the eye, radiating to the forehead. And crucially, this severe pain triggers systemic responses via nerve connections. Intense nausea and vomiting are very common.
Nausea and vomiting.
Yeah.
So someone might end up in the ER thinking they have a terrible migraine or even a stomach bug.
Or even classically an acute abdomen because the vagus nerve irritation can mimic abdominal emergencies. If the ER doc isn't thinking about the eye, precious time can be lost. Misdiagnosis is a real risk here.
So if it is diagnosed correctly, what's the immediate action?
You have to get that pressure down fast. And usually topical eye drops alone aren't enough initially because the pressure is so high. So you start with systemic medications. Intravenous mannitol, an osmotic agent that pulls fluid out of the eye into the bloodstream. And often IV acetazolamide, a carbonic anhydrase inhibitor that drastically reduces the eye's fluid production.
Hit it hard systemically first.
Right. Once the pressure starts to come down with the IV meds, then you add intensive topical drops, usually things like pilocarpine, which constricts the pupil. Pulling the iris tight and away from the drainage angle can sometimes help break the blockage physically. The goal is to stabilize the eye, then usually perform a laser procedure, laser peripheral iridotomy, shortly after to create a permanent bypass channel for the fluid, preventing future attacks.
Okay, let's talk about another terrifying scenario. Sudden, painless blindness from a vascular occlusion. Starting with the artery central retinal artery occlusion, CRAO.
CRAO is. Yeah, it's devastating. It's a sudden, profound loss of vision in one eye, usually painless. Think of it as a stroke occurring directly in the main artery supplying the retina.
And the outlook is usually pretty bad.
Generally, yes. The prognosis for vision recovery is very poor. The inner retinal layers, especially the ganglion cells whose axons form the optic nerve, are extremely sensitive to lack of oxygen hypoxia. Irreversible damage can start setting in within maybe 90 minutes or so.
Is there a classic sign you look for inside the eye?
There is. It's the cherry red spot. What happens is the inner retina, starved of blood, swells up and becomes pale and opaque, almost milky white. But the very center, the fovea in the macula, has a slightly different blood supply, partly from the choroid layer underneath. This underlying circulation keeps that tiny central spot looking relatively normal, reddish. So you see this dramatic contrast, a bright cherry red spot standing out against a pale ischemic background.
And the cause is often an embolus, a clot that traveled there. So the eye problem signals a bigger systemic issue.
Almost always, yes. A CRAO is usually caused by an embolus lodging in that central artery. The clot most often comes from either hardened plaques breaking off from the carotid artery in the neck or sometimes from the heart, especially if there's atrial fibrillation. So while we might try emergency measures to dislodge the clot in the eye itself, like ocular massage or rapidly lowering IOP, the real long-term urgency is a full systemic workup, checking the carotids, checking the heart to find the source, and prevent a potentially much larger life-threatening stroke in the brain.
The sources really stress that point surviving a CRAO means you're at much higher risk for a future stroke or heart attack.
Absolutely. The eye acted as the canary in the coal mine. It's signaling significant unstable vascular disease.
How does that differ from a central retinal vein occlusion, a CRVO?
A CRVO is also usually sudden vision loss, but often it's not quite as severe or total as a CRAO. It's caused by a blockage in the main vein draining blood out of the retina. So instead of lack of inflow, you get a backup.
Like a plumbing backup.
Exactly. Blood can't get out, pressure builds up in the retinal capillaries, and they start to leak badly. When you look inside, the fundus appearance is dramatically different from a CRAO. You see widespread retinal hemorrhages, often described as looking like blood and thunder, with streaks and blots of blood all over the retina, plus swelling, edema, and dilated, tortuous veins.
Still linked to things like high blood pressure.
Yes, hypertension and atherosclerosis are major risk factors, just like for CRAO. But with CRVO, especially in younger patients, we also need to think more strongly about potential blood clotting disorders, problems with hypercoagulability. So the workup might include specific blood tests looking for those underlying issues.
Okay, let's zoom out for a moment to the global perspective. We focus a lot on these dramatic emergencies, but what did the sources say remains the single biggest cause of blindness worldwide, even though it's treatable?
That unfortunate title still belongs to cataract, just clouding of the natural lens. The WHO data cited suggested cataract accounts for something like 51% of all global blindness, half the cases.
Wow. And the difference is just access and timing.
Largely, yes. In developed countries, we tend to have cataract surgery when the vision starts to interfere significantly with daily life, driving, reading. In many resource-poor settings, people often don't get access to surgery until the cataract is incredibly dense, completely mature, and they are profoundly blind in that eye. The surgical challenge is greater then, too, so it's a massive public health issue globally.
The sources also mentioned some really tough infectious diseases and genetic factors impacting vision in specific regions. River blindness.
Onchocerciasis, or river blindness, a truly devastating parasitic disease, mainly in parts of Africa and Latin America. It's spread by the bite of infected black flies that breed near fast-flowing rivers. The larval worms migrate through the body, including the eye, where they cause intense inflammation, severe uveitis, clouding of the cornea, keratitis, and eventually damage to the optic nerve, optic atrophy, leading to blindness.
And controlling it is a huge undertaking. Massive. Treatment requires community-wide annual doses of the drug ivermectin, often for 10-15 years or more, to kill the larvae and break the cycle of transmission.
Yeah.
Huge public health campaigns have made progress, but it's a long fight.
And what about sickle cell anemia? We think of it as a blood disorder, but it has major eye impacts, especially in certain populations.
Right, sickle cell anemia. It's genetically common in areas where malaria is or was endemic because carrying the sickle cell trait actually gives some protection against malaria. But the disease itself causes red blood cells to distort into a stiff sickle shape.
Which blocks small blood vessels.
Exactly, including the tiny vessels in the periphery of the retina. This blockage leads to ischemia, lack of oxygen, which can then trigger the growth of abnormal new blood vessels, new vascularization, similar to diabetic retinopathy, but often happening in younger adults. These vessels can bleed or lead to retinal detachments. It mimics age-related vascular disease. but decades earlier.
And lastly, a really concerning one. Ebola survivors facing late eye problems. Yeah, this was quite a discovery. Some people who survived Ebola virus disease later developed severe inflammation inside the eye, a hemorrhagic uveitis, sometimes months after they'd cleared the virus systemically.
The virus lingers in the eye.
That seems to be the case. The eye is considered an immune-privileged site, meaning the immune system's surveillance isn't as active there. So the theory is that the Ebola virus can hide out, persisting within the eye long after the body has fought it off elsewhere. Then something triggers it to reactivate, causing this really destructive inflammation that can severely damage vision. It's a stark reminder of how the eye can be a reservoir for infection. #OutChag_outro.
So wrapping this deep dive up, it is really clear the eye isn't just this isolated camera. It's more like a dashboard indicator for the whole body. We saw how the blood vessels in the back clearly show the impact of chronic hypertension, the progression of diabetes.
Yeah, it's like a vascular report card back there. And we saw how those core diagnostic tools, checking pressure with tonometry, mapping the field with perimetry, they aren't just routine checks, they're absolutely essential for catching silent thieves of sight like glaucoma. And critically, that information we get from the eye, like seeing those cotton wool spots, has direct, potentially life-saving implications for preventing major systemic events like stroke.
The big takeaway for everyone listening has to be that getting a proper professional eye exam isn't just about updating your glasses prescription. It's a fundamental health check. It could be the first place a potentially life-threatening condition gets picked up, maybe long before you have any other symptoms. Your eye health and your overall systemic health, cardiovascular, neurological, they're just intrinsically linked.
Absolutely. Which leads us to maybe a final provocative thought for you to consider. We've established today that the signs are there, right? The evidence of major systemic diseases like high blood pressure, diabetes, microvascular damage, it's visibly locked away in the intricate details of the retina and cornea. So the question becomes, given how common these diseases are globally, and how non-invasive and increasingly affordable things like retinal photography and advanced corneal imaging are becoming, how can we better leverage this technology? Could we use these simple, quick eye imaging tools to screen huge numbers of at-risk people for systemic diseases outside the specialist's office, maybe integrating them into primary care checkups, pharmacies, or even mobile public health screenings?
If the evidence is literally visible in the eye, how do we make seeing that evidence, making that diagnosis more accessible for everyone who needs it? That's definitely something to think about. Until next time on The Deep Dive, keep looking deeper.